Dementia in Wales, what's your sense of the main issues that need to be addressed?
I think there are a number of issues that we can look at dementia afresh. Firstly, it's the realisation that dementia is not inevitable. The prevalence figures are, for an 85-year-old, about 1 in 4 in the UK. However, in the USA, it's about 1 in 2. I find that figure really frightening, and we may like to remember that the USA is probably about 20 to 30 years ahead of us in terms of the obesity epidemic. So for those of us in general practice, prevention, health promotion is very much core. What's good for the heart is good for the head. And I think that's a message that we really need to vitalise primary care, that it's not just preventing diabetes and heart disease, but we can do something really important. It may not be for years, but even to delay the onset by 6 months, 12 months, will have a very significant result and benefit to society.
You mentioned that we tend to start with the assumption that dementia is inevitable. In what way would you like us to begin thinking differently?
We can't necessarily prevent all types of dementia. It's an area for research. However, 20% of dementia may be vascular, and 20% may be vascular mixed with Alzheimer's. So there are huge areas where we can look after our weight, stop smoking, manage blood pressure, cholesterol. These are primary core issues. So again, reiterating, what's good for the heart is good for the head, as well as our attitude to seeing people as what they can do rather than what they can't do. And this comes back to the theme of dementia as a disability rather than as a disease that takes over.
I guess it's what you term reframing. How might we begin to reframe the way that we think about people with dementia?
Again, it comes back to the being able to see what people can do rather than the disease taking over everything. There was a lovely story from the Scottish group of a young woman who couldn't remember, grandmother couldn't remember what she had done, but her grandmother had taught her Fair Isle knitting. What was she valued? The fact that she couldn't remember what she'd done that day, or the fact that she could pass on a skill which defies me even when I am at my, hopefully, my intellectual prime. So valuing people for what they can do, and it's the reframing that it's a disability run, and that opens up all sorts of possibilities to be creative in how we respond to the services that may support patients and carers.
You've got several headings in your list of the main issues that need to be addressed.
The second is about realising that early recognition is important for both patients and carers. It gives them choices, not only practical choices about access to benefits, but also choices over how they want to live with the condition. And there is increasing realisation that we need to reframe dementia not as a disease which takes over, but as a disability which is a part of the individual, and therefore we can respect and retain personhood. And in that sense, it's very important for those of us in primary care to engage with the patient, but also to help the patient and the carers remain engaged within society.
And what about the patients themselves?
We need to support patients to make good choices and not confront them with decisions that have been made on their behalf. And this comes back to the very basic essence of personhood, is respecting individuals and being very much more creative in how we offer them choices. It doesn't always have to be confrontation, and unfortunately many patients with more advanced dementia are labelled as being aggressive, when in reality you or I might be rather uncomfortable about being undressed or washed by strangers who speak a language we don't quite understand. So I think we need to respond to the basic humanity, personhood of the individual. You
also talk about secondary care as being something that we need to do differently. What are the priorities there?
I think we need to distinguish between secondary care mental health services and secondary care in the acute setting. I am very concerned about secondary care in the acute setting. For example, my patients with dementia are more likely to be admitted to hospital, they're more likely to have longer stays, they're more likely to develop chest infections, have strokes, have falls, break their hips, they're more likely to pick up MRSA, C. difficile, they're more likely to be malnourished. It doesn't get any better, and we haven't even mentioned challenging behaviour. So I think secondary care, it is in their interests as well as the interests of our patients to understand our patients when they go in. That's why the Alzheimer's Society This Is Me leaflet is important in very basic things like respecting the patient and what they like to be called. Not everyone of advanced years with dementia wants to be called by their first name. Some may actually not respond to their first name or their married name, but their maiden name. Those are very basic things. Behaviour such as shouting out isn't always about being awkward. It may be because you're in pain. And it's a lot of evidence that shows that patients with, in the acute setting with pain receive less in forms of analgesia. And yet we know that people as they get older are more likely to have back pain and joint pains. So this is about actually trying to decode what the patient's behaviour is trying to tell, and not to humiliate, embarrass or talk over them because they don't cooperate with our time schedule or our shift work. And so there is evidence that nutritional support in hospital, actually having somebody feed a patient if they can't feed themselves or can't recognise that food is food or that a cup is something that you drink from, can actually promote early discharge because they're less likely to develop wounds or pressure sores. Also, it's important to actually have dementia liaison nurses who can be there to support patients with dementia in the acute setting, which is very frightening for patients who do not have dementia. It's even more so if you're unable to understand what's going on.
You've talked about the way that primary care relates to people with dementia and their carers. In what way do you think those relationships could be different?
I think we need to value our carers. They may be engaged with us in a very real sense because 1 in 2 carers has chronic health problems, so we may be seeing them. They take the burden of care and save the state enormous amounts of money. They are often in a situation where they are referred for support, but the support that is on offer doesn't actually meet their needs. Again, if you listen to carers, their main problem is finding time to do very simple things like going to the doctors, having a dental appointment, and that's very difficult. They may be offered a service that is a sitting service at night, but actually the sitter will get up and wake up the carer if there is a problem. Defeats the whole object of having at least 6 hours beauty sleep. You get in a situation where services may offer a care package, which means getting somebody up at 9 o'clock in the morning and putting them back to bed at 4:30 in the evening. I don't know how many of you go to bed at 4:30 in the afternoon, but that may be what's on offer, but that's obviously not what is required for the carer or for the individual. And then it becomes a very profound human rights issue. So I think we need to do much more listening to what carers actually need.
Tell me a bit about pain assessment and how that has an impact on people with dementia.
The end stage of dementia is characterised by loss of memory, loss of recognition, loss of speech and loss of the ability to do things. So you have a patient who is in their last illness. Unlike cancer, the disease trajectory is not a steady decline. It's more of a wobbly line. And it's very difficult to predict when somebody is going to die. That is an area for research. However, as you get older, we know that elderly people have more back pain, joint pains. I don't think patients with dementia are any different. However, when you look at their prescriptions for pain relief, it's remarkably lower. So again, a difficult area to do research, but what we know from the acute sector is that patients who have acute pain, if they're elderly, about 70% may have pain relief, but if they have dementia, about 17%. So this is an area where, again, I don't think people are deliberately being cruel, but if somebody's not crying out and demanding pain relief, it's often perceived that they don't need it. And coming back to the ABCD and the D for decode the behaviour, we need to actually understand what their behaviour is telling us. And so it may be that they are more agitated, more confused, they are shouting out. There are pain scales that are available, and these need to be more commonly used. And certainly another area for research has to be validated. But I think the answer is, as it is at now, it's not good enough.
And how would you sum all of this up? What's the key message?
I think the key message is that we need to recognise that what's good for the heart is good for the head. We need to be very much more positive about living with dementia for patients and for carers, and to get over the message that this is a disability rather than a disease that takes over and loses personhood. People are important. We need to enhance living with dementia rather than prematurely dying with dementia.